I'm Carolyn Davies, and I'm a project officer at the Centre for Excellence in Child and Family Welfare. I'm joined by my colleague Emma Nugent, as well as various other panellists that you can see on your screen, and I'll introduce people in just a second. I'll just start by acknowledging traditional lands on where we live and work. I myself am on the unceded land of the Wurundjeri people, and I pay respect to elders past, present and emerging, including any Aboriginal colleagues joining today. For those not familiar with this webinar series, each session we take a different topic or theme, which hopefully helps us to better understand the nature of adolescents who use violence in the home. So we try to meet with professionals from different fields of expertise, and we encourage participants to ask questions as we go along. You can do that by entering thoughts or questions into the Q&A box. As I mentioned, we will record the conversation today, and we can make that available as well as any slides to participants after today. So first up, in our session today, we will be hearing from Maddison Riachi, who is a current doctoral candidate completing her Doctor of Psychology in Clinical and Forensic Studies at Swinburne University and the Centre of Forensic Behavioural Science. Maddison has recently completed a study investigating the topic of mental health and the mental health service utilisation of young people who use violence at home. So she'll be sharing some of the key findings from that research. And then on a similar topic, we are joined by Danny Gold, Zanetta Hartley and Courtney Lecanto, who are all specialist family violence advisors in mental health. And so hopefully we'll get some good discussions. And like I said, we'd love to hear from people with any questions. So please add those to the Q&A box. So today we'll start by passing over to Maddison, if you'd like to give us a bit of a rundown and some insights into the study that you looked at.
No worries. Thanks very much, Carolyn, and thanks for having me here. So I am actually currently in Melbourne at the moment, doing this from a friend's computer system. So I'm sorry if at times I look a little bit spaced out. It's because I'm still adjusting to what's going on my end. Like the introduction said, so I'm a current doctoral candidate at Swinburne University in the Centre for Forensic Behavioural Science, and recently submitted my thesis all looking at the mental health and mental health service use of young people who engage in violence in the home. So I'd like to also acknowledge the authors of, who are also co-authors of this work, which is my supervisory team, Associate Professor Troy McEwen, Dr. Benjamin Spivak and Dr. Nina Papalia. Alrighty, let's get going. Okay, great. So just to kind of give a little bit of context around when I say youth family violence, I did my work on youth family violence, and that kind of encapsulates a lot of different forms of this behaviour. So we're talking about adolescent violence in the home, dating violence, which is similar to youth intimate partner violence, child to parent violence, and then sibling to sibling violence as well. What we kind of know from previous research is that these different forms of youth family violence have very much been investigated in isolation from one another. However, recently in the last 2 years, there's been a big push to really start to look at the overlap between these different forms and what similarities they have, because as we kind of see over time, there is actually engagement in these different forms as a child develops. So usually sibling to sibling abuse or violence is kind of the first behaviour that we see, which then can have a young person later engage in child to parent violence, and then later youth intimate partner violence. So they're kind of all interconnected in a way, is what we're trying to see at the moment. So I guess with that overlap, what we see from then on is an overlap in the correlates of these different forms of violence. So these are the three kind of main forms up there. So your youth intimate partner violence, your child to parent violence, and your sibling to sibling violence. But there are also obviously other forms. These are just the kind of three main ones that have had the most research, with youth intimate partner violence being the most researched to date. So kind of an important thing to note when we're looking at this table is that I'm talking about correlates, because there's been a real deficit in longitudinal studies that look at the relationship between different factors of interest and engaging in these behaviours over time. So we can't actually say for certain whether these are risk factors. So these are correlates. And there's kind of an absence of any substantiated theory that ties all of these different forms of youth family violence together. So kind of the best way for me to explain these correlates is using the socio-ecological model, which you can see on the top right hand of the page. So the different levels, we've got the ontogenetic level, which is your individual factors, your microsystem level, which is your relationship factors, ecosystem level, which is looking at religious or school factors, and then at your macrosystem level, that's kind of your more wider cultural factors. Now, you can enact change at any level of this system, but what we kind of know is that looking at the individual factors can really help us get an understanding of why people engage in this behaviour, and what we can do to change at an individual level to reduce the likelihood of further incidents of violence. So if we do look at that individual factor level, in bold, what I've done is put the things that are common across all three different forms. Obviously, conduct problems and antisocial behaviour are also there across all three forms, but the research to date is kind of very varied. It's not very well defined in terms of what conduct problems are we talking about, what antisocial behaviours are we talking about. So it's kind of really still very unclear. So that's why that one hasn't been put in bold. And where you see an asterisk, that's where these correlates have also been found in the victim survivor population of that form of violence. And so what we see is mental health is one of those ones there. And as much as I'd love to dive into all four of those, I could only do one. So that's where our research came in with a focus on mental health. So in terms of mental health, we broke it into mental health service use and mental health diagnoses. We got our sample from Victoria Police, a total of 361 dyads. These dyads were all unique, so there was kind of no overlap between one dyad appearing multiple times. And I think it's really important to keep in mind when I'm talking about the results of this research that we're at the pointy end of youth family violence. These are young people who have come in contact with police because of incidents of youth family violence. And as we kind of all know, there are so many incidents of youth family violence that don't come to the attention of police, and some families that will never end up calling the police for assistance. So just kind of keeping that in the back of your mind. We also looked at young people who were 25 and below, so also getting into that young adult population as well, which is quite an underserviced population in terms of youth family violence work. So let's break it down. Mental health service use. When I'm talking about mental health service use, I'm referring to these different tiers over here. So tier 1 is your Medicare rebated services. So your private psychologist or psychiatrist or mental health social worker, everyone that can get the Medicare rebate. So that's your tier 1 contacts. Your tier 2 is your public mental health contacts. So we're thinking our KIMs or our CAMs. And then tier 3 is our most acute. So our public mental health admissions and emergency contacts. So for these young people or victim survivors for that matter who have had to be admitted to a psychiatric ward or have come in contact with the emergency department or perhaps the critical assessment and treatment teams as well. So what I've done in that graph over there, I've provided the prevalence rates for both youth family violence users and victim survivors. And what we see is kind of what we expect in terms of the prevalence of contacts for each of those tiers decreasing as the tiers go up in acuity. So kind of give specific numbers overall for youth family violence users. We saw a total of 74% accessing any mental health service use, and this was over a period of 8 years. So some people may have had way more contacts than others, but overall over that 8-year period, 74% of these people accessed a mental health service at least. And for victim survivors, we had a total of 67% accessing any mental health service use. So we did go further than just looking at prevalence rates, as fun as they are. So we did some multi-level regression analyses, boring, and these are kind of more distinct results that we had. So I know there's a lot of text there, I'll just break it down. So in terms of one thing of interest, when we looked across different forms of youth family violence, we found that there was actually no difference in their mental health service use. So unfortunately, we couldn't look at sibling to sibling violence. We just didn't have the right relationship to code, but we did look at youth intimate partner violence and child to parent violence. And for both users and victim survivors, there was no difference in their mental health service use, which is kind of not surprising given the overlap that we see across those different forms of violence. Another interesting thing is that for those that were engaging in violence across multiple relationships, we saw a higher count of mental health service contacts. And for victim survivors, those that actually had a history of family violence use, they had a higher count of mental health service contacts as well. So there's something about the use of violence or that ends up with a higher level of mental health service contacts, potentially indicating that there's a higher level of psychological distress there. And kind of what we would expect, people who were victimized across multiple relationships, they also had a higher count of mental health service contacts as well. And probably of the most interest to us was in looking at the temporal association. We found there was a temporal relationship for youth family violence users, but not youth family violence victim survivors. So what am I talking about? We found that for youth family violence users, they were 1.82 times more likely to engage in family violence when they had had a mental health service contact in the last 3 months. But there was no temporal association after this. So it seems to be there is a clear lead up indicated by the contact of mental health service use before there is a family violence incident. However, for victimization, that wasn't there. There was no clear link between the two. So mental health diagnoses. Once again, put the prevalence rates there. I think it's also important to note that unfortunately Medicare doesn't actually record mental health diagnoses in the data that we were provided anyway. And so these diagnoses were only for people who access tier 2 and tier 3 mental health services, so your public mental health services. What we see is that for youth family violence users, the most common diagnosis was substance use disorders, followed by stress and anxiety disorders, and then mood disorders. And also, I think when I talk about stress and anxiety disorders, to break it down even further, it was actually mainly stress disorders that we were seeing. So your PTSD, your adjustment disorders, those kind of things. And then for victim survivors, still those 3 most common diagnoses, but mood disorders were the most common, followed by stress and anxiety, and then substance use disorders. Unfortunately, with substance use disorders, obviously really broad, and couldn't actually get a specific breakdown of what substances we were seeing. But I think that was just an interesting finding in terms of, at least for these young people, substance use appears to be a really key thing, which I guess is also not surprising given the literature that shows there is a link between substance use and violence in an adult population, but also in a youth population as well. So kind of we're seeing a same pattern happening with mental health diagnoses, in which violence use is really increasing the likelihood of being diagnosed with a mental health disorder for users, but also for victim survivors. So for victim survivors, if they had had a history of family violence use, they had a higher likelihood of being diagnosed with a mental health disorder. And in terms of victimization across multiple relationships for the victim survivors, it was only a higher likelihood of anxiety and stress disorders, no other disorder or overall. In terms of across youth family violence forms, there was no difference in terms of the likelihood of diagnoses for youth intimate partner violence users and child to parent violence users, which once again is not surprising. And then similarly, we also found that there was a temporal relationship for youth family violence users, but not victim survivors. So youth family violence users were actually more likely to receive a diagnosis prior to their initial contact with police regarding youth family violence, as opposed to after. Whereas for victim survivors, there was actually no difference in the likelihood of receiving a diagnosis before or after the onset of contact for family violence, for youth family violence victimization. So what does all of this mean? First of all, mental health and mental health service use across the different types of youth family violence use is more alike than different. So kind of really solidifying the argument that has come out in the last 2 years, that there's clearly overlap between these different forms, and we need to be thinking about the young person as they progress through their development and the potential to engage in these forms of violence across that development, and that actually we need to be treating this as kind of very similar rather than distinct different forms of behaviour. In terms of where mental health and mental health service use comes in to youth family violence, well, we found that for youth family violence use, it actually may be more a risk factor than a risk marker. So moving away from correlates, because we've got that longitudinal information now, and actually mental health may play an important role in working out why do these young people engage in this behaviour. However, for youth family violence victimisation, it doesn't appear to be as much of a risk factor. I mean, that can be we could have not found a temporal relationship for so many different reasons, potentially because, as most of us know, the adverse impacts of family violence are cumulative. They become more intense over time. And so when we just look at a point in time, we're not necessarily going to find that temporal relationship in that point in time. And there's also multiple barriers for victims of abuse to be able to receive help and seek help and go to receive some kind of mental health service contact. So that can also be a potential explanation. But overall, we're potentially seeing mental health as a vulnerability factor because it's clearly still there in that population, just doesn't seem to be interacting with incidents of youth family violence victimisation. But I think it's just really important to note that mental health is only one of a myriad of different potential risk factors. So, for example, substance use, which is something that obviously came across in the diagnoses, is something to also consider, as well as other dynamic risk factors. However, we don't know what those risk factors are because we haven't done the research yet. And this is just kind of one of the main things about this field, is that the research is so far behind what is needed in practice, which can be really frustrating. And also, I guess what we see in the research in general is that our research suggests that there may be a direct or indirect causal relationship between psychological distress, as indicated by mental health service contacts, and then youth family violence use in some cases. So this in turn suggests that recognising high levels of psychological distress and intervening could be one way to reduce subsequent incidents of youth family violence. But this is obviously not to say that victim survivors should not be afforded quality interventions as well, because we need them to reduce the impacts of youth family violence victimisation. I know that a lot of you are practitioners, so I wanted to kind of make sure I outlined key messages for practitioners working with this population. So I wish I could give you kind of a clear-cut, straight answer, but unfortunately I can't. So kind of continuing what's best practice at the moment, so a formulation-driven individualized treatment is still the best way to go, particularly in the absence of substantiated theory for this behaviour. So it's really looking at, okay, what are the known correlates of youth family violence? Okay, is mental health one of the things that might be playing into this young person's behaviour? What is the role of mental health for this young person with their behaviour? But are there other factors that are interacting with mental health? And are there potentially other factors that might have a greater influence over this young person's behaviour? Kind of taking that view of looking at the different potential factors, seeing how they interact, and then creating a treatment plan from there, rather than a one-size-fits-all approach for these young people. In terms of mental health services, we kind of see that they're really well placed to be able to intervene with this population. So screening for youth family violence may be a thing that could be quite important, which may also play into, I've moved to Queensland now, so I'm a bit behind, but last time I left Victoria, they were looking at creating the adolescent version of the MARAM. So I'm not sure if that's come out yet, but if so, that's really great for starting to screen for these behaviours in these young people. And then in terms of youth family violence focused interventions being provided in tandem with mental health treatment, if mental health is there for that young person, because this is such a complex behaviour, we need to have a cohesive multidisciplinary team to work with these young people. It can be really overwhelming for one practitioner to be left with the responsibility to treat both the mental health and these behaviours, and you really need kind of a specialised lens to deal with the behaviour, and a specialised lens for the mental health treatment. So in terms of kind of a useful resource, the Youth Forensic Specialist Service, which is attached to the Alfred Kims, provides secondary consultations and primary assessments for young people engaging in youth family violence, as well as other behaviours. But I've just provided their intake email there for anyone that might be feeling a little bit overwhelmed by what a client might be presenting with, and just perhaps wants to get a little bit more information about what to do next. Or maybe you think that this young person does need a proper assessment. So feel free to get in contact with them. They service the south and eastern regions of Melbourne, all the way out to Gippsland area. But if you're in the north or west of Melbourne, I'm sure they could potentially help point you in the right direction of who to speak to. So that's it from me. My email is there. I'm free if you would like to get a copy of the slides, email me, I'll send them directly to you. And happy to take any questions or queries. And I'll let Carolyn kind of work out when those questions can be answered. But thank you so much.
We have Danny Gold and Courtney Lecanto and Zanetta Hartley, who I mentioned briefly before, but I might get someone just to briefly describe the role that you are in, because my understanding is that this role is sort of universal throughout different regions, mental health catchment areas in Victoria. Could I get one of the three of you perhaps just to give us a brief rundown for people who are not aware of that role?
So we are what's called Specialist Family Violence Advisors in mental health. And as you mentioned, Carolyn, across the state, depending on which area-based service you are geographically located in is what you're attached to. So I currently cover the Loddon, Campaspe and Southern Mallee regions of Victoria. So I come from rural regional areas and I work for Bendigo Health. And I'd really like Danny and Zanetta to introduce themselves and their services if possible too.
Hi, I'm Zanetta Hartley. I am the Specialist Family Violence Advisor for Northwestern Mental Health, and I cover Origin Specialist Program, which is a specialist service working with adolescent mental health.
Hello, and I'm Danny Gold. I'm based at the Royal Children's Hospital. So my role as a family violence advisor is specifically around children and adolescents in that context.
I guess maybe that first question we might turn our attention to is that Maddie talked about mental health services being well placed to possibly identify and intervene in a young person's use of violence. And to answer your question earlier, Maddie, no, there is not currently an adolescent focused MARAM practice guide in place. That is something that's currently in development. So I guess my question to panelists then is how is adolescent violence identified by youth mental health services?
In Victoria, we are rolling out the MARAM framework, so multi-agency risk assessment and management framework. Part of our roles as specialist family violence advisors are to assist our organisations in rolling these out. When it comes, as the adolescent tool has not yet been released, when it comes to identifying adolescent violence in the home, it's really about building trust, not only with the consumer or the adolescent that we're working with, but also the family and the supports around the adolescent, and how it can be disclosed or identified is in a number of different arrays of, there can be that concern that during assessments and intake that there's certain red flag indicators, the treating teams may be picking up on certain signs, or certain disclosures of family violence, but it really is about building that rapport and that trust for a young person to feel comfortable, or for that family to feel comfortable to be able to disclose. And a lot of those disclosures are first time, and it is to the adolescent mental health team. I'm going to give Courtney and Danny some time to answer and reflect on that too.
Danny, did you want to go next?
Sure. I guess what I'd say, just reflecting on sort of the practice experience, is that it turns up in a lot of ways. Often the referrals come with something that says history of family violence, and then we really need to unpack that. Often it comes through as a referral that says behaviours of concern. Often, and that would be often in the context of someone who presents with neurodivergence of different sorts, and we might put different phrases or terms based on how they come through the door of the service. I think also we get a lot through emergency departments. Police will turn up, ambulance will turn up. This kid is causing either a scene on the street or at school or in the family home. They've been called by family, but more often called by others, and so it's identified that way through coming in through a sort of emergency service response. I think that we are getting better at asking about the use of violence and its functionality, but I would just really stress that depending on how it comes in. So if, for example, we know that there's a young person who's very dysregulated in their school or home environment in terms of their behaviour that's presented, their externalising behaviour, that's how we might start to assess it and talk about it. But I would hesitate and say that there is a difference between specifically going in and asking about adolescent use of violence in a family violence context and adolescents who present with behaviours that are violent. And I think that's probably as a system where we're up to.
Yeah, that's a really important note to make there. And that I think, in our conversations earlier, we talked about the fact that going in, with a young person and family and immediately trying to address, sort of asking a young person about their use of violence is not the best way to initially, I guess, engage them in conversation or build rapport with that young person. Speaking about families, I guess one thing that we've heard a lot from practitioners is that working with families and working in a really holistic, systemic way seems to be really important in looking for solutions around adolescent use of violence at home. And I guess I wanted to ask about, from a mental health context or perspective, is there capacity for mental health practitioners to engage with other family members and to do that kind of holistic work, or is it fairly child and youth focused in their approach?
I'm happy to talk to this, and then Danny and Zanetta, I reckon you can both jump in with your particular service sector's perspectives. I think it's important to understand that for most parts of mental health, they don't see children and young people just as their own parts. You know, they come from families, they're in family environments. Whatever that looks like is the complexity of the environment that they're working with. So, and to actually work with children and young people, you do need to work with their families. The practicalities of getting just access to them, but also to understand that the environment, what is going on for them. Sometimes, I think, picking up on Danny's point earlier, our service systems see the behaviour. So some families might actually just lead with a conversation about a young person's behaviour. We have to have this position of curiosity where we actually go, what's actually happening for this young person with this behaviour? We have to think about the why, as well as then how do we support the safety? How do we actually support treatment? What does this look like? So we do have to think about it more holistically as well. I think as a service system, we'll continue to improve on that. And I sit here with all humility, acknowledging we've had a Royal Commission into family violence and also into mental health. There's been 2 in Victoria. So we're actually talking about a subject today that's potentially at the intersection of both of these pieces of reform and kind of needs that position of curiosity given to it.
Yeah, I think curiosity is a good position going into enable practitioners to try to think holistically and not just go in with their own ideas about what's going to work for that young person and family. So Maddie touched on before about the idea of there being 3 tiers of potential access points within the mental health system. Are there ways of supporting a young person with their mental health if the young person is saying they don't want to engage around mental health? It might be that another service could be child protection or some other type of adolescent case management are already working with the young person and the family. I guess I'm speaking on behalf of practitioners who've said they feel like they're suddenly having to hold, this complexity, and they're not really sure about how to get the necessary help for that young person. Are there ways that, is secondary consults an option, or if the young person doesn't quite meet eligibility criteria, are there other ways to get that young person that mental health support?
Yeah.
Sorry, Danny. No, you go.
I think there are lots of ways to support a young person into their own support, and I choose that phrase pretty intentionally because if we think about it, it's still usually adults who are pushing young people into a service response. And the most important thing, regardless of where they turn up in the system, is how we engage them as young people, as humans, as something that they want to address. So when we think about the use of violence, it's often got a very functional use. And so if they don't see any purpose in removing that useful behaviour, we can't expect them to engage. So the very, very first thing is to find who they are in the world and to link in with them, regardless of if that's substance use or violence or a physical injury. We really have to engage the young person, because remembering that behaviours and expressions are ways of talking to us, and they have a function, and they've had a function that has been really useful for a long time. So if we want to start to unpack and shift the use of that behaviour to another behaviour that's more functional currently, we need to actually make that connection with the young person. And I focus on that strongly because I think it's really important that we don't see young people using violence as different from any other young person that we choose to work with. If we think we have a skill in working with adolescents, we have a skill in working with adolescents. It's not that this is a big, scary, different issue. It's a really complex issue. But remembering that if you are a youth worker, you are the only person in that young person's world potentially who is focusing on them rather than on all the adults, whether they're schools, families, police, courts, whoever, who is defining the impact of their response to the world. So I really I'll stop there and let Zanetta talk a bit more structurally, but that's my very, very strong bent, is that we need to engage the young person as a partner for them first, and then we can look at the rest of the system.
That's such so beautifully said, Danny, and I think it's a very important message. I also, you know, if you know a young person is linked to a mental health service or has a GP, there is a diagnosis, there's nothing wrong in calling up and asking for a secondary consult, learning more about what that diagnosis might be, you know, how the treating team might be working with that young person, whether that young person's engaging with the team or not. In Victoria, we're so lucky to have the information sharing schemes where we can share information. And of course, we wouldn't want to do that behind a young person's back. Of course, we know getting consent is always best practice, but there's times where you can't. And I know from my work in direct practice in family violence, working with adult victim survivors, when they were also linked with the mental health sector, the best part of my practice was, one, talking to that person about their expertise in their own mental health, but also the teams around them to get a better understanding. And it didn't mean I needed a full medical degree, but I just needed to have a more understanding of, you know, what are the mental health safety plans with this young person, and how can we add in a family violence safety plan here for whole of family. You know, what can we be doing with the schools? You know, are they violent at school? No. Are they really well respected by their peers and their teachers? I think we're lucky now. Again, the information sharing schemes are so powerful and part of MARAM, and can be really utilised to help support a young person and to help each one of us understand each other's sectors better, but also doing that secondary consult both ways. Also talking to the mental health teams. We know what we know and we're experts in what we are experts in, but that just because someone is a doctor or a psychologist, psychiatrist, doesn't mean they know everything. So it's a two-way street with that education and providing that information back too, especially if you've got a really good rapport and relationship with that young person, and you can feed back to the treating team, you know, what's working for them, what's not. And it can be quite scary because we do work as big teams. You know, a young person in mental health isn't going to see just one key clinician. It is a whole team of professionals that will be working with this young person. So you might go to a meeting and there might be 5 to 10 different people from the mental health service, but each of those people will come with curiosities around the advice and information you'll be asked to provide, and reflected back also.
Picking up on your point, Zanetta, about the secondary consultation, I think it's really important, because I think it's a frustration of external service systems at times to actually go, we've got a young person, there's all this behaviour happening, it's clearly a mental health issue. And that's why we invite that position of curiosity. We invite you to actually collaborate, have those conversations, reach out and do those secondary consultations, because sometimes when we see behaviour and we don't quite know how to explain it, our default position as service sectors can be to actually give it a label of mental health, of it must be mental illness, whereas sometimes it's actually not. And I think that can be really complex for service systems to sit with. And just because, all right, perhaps it does have a diagnosis, all right, perhaps that young person is actually really unwell, they're acutely unwell. The next complexity, I think, for people external to the mental health service sector is actually whether they meet that threshold. So Maddison talked about the different tiers, and I think that's important for service sectors to understand, because just because somebody doesn't actually meet perhaps the current threshold of accessing our service system doesn't mean they can't access mental health supports. It just would be about where in the service system that young person is needing the support that matches for them.
Speaking about access and I guess potential barriers for young people accessing support, I guess I just wanted to touch really briefly, and then hopefully we can go to some audience questions, but just that idea of, you know, there is this, you know, culmination of different services all working really busily in Melbourne, and then what we're hearing from practitioners is that working in regional areas, it looks very different because of sparsity of services and different access types to resources. So can you just touch on, and maybe Courtney might be best placed, just to talk briefly about regional differences around access to mental health supports, and I think also just touching on that idea of telehealth models of intervention? Is that a thing? Is that something which is helpful for families and young people?
Sure. I don't think it's probably a secret in rural regional areas that we don't have access to the same level of specialist support. So even Maddie's great point around what the Alfred has obviously covers the southeastern part of the state. That is not my area. So for us, we have to actually still go back to how we've always worked, which is relationally based. We have to rely on each other, but also then that point of engagement with young people is incredibly important, because you also have to then understand, if we are actually looking at support services, what does the young people actually think about it? If there's only a specialist inpatient unit for young people and that is based in Metro Melbourne, what does that look for, like that young person to leave an area? What does that look like for that family? And what sort of supports do they actually need to be engaged in that kind of decision making? I think then if we actually have a level of intersectionality about this, and we're looking at young people who are maybe Aboriginal, Torres Strait Islander, what does it look like for them to leave country and access services? That's actually the complexity of what we're thinking about. And we have to be curious about that, because if for a young person that is not something that they're able to do, what are our alternatives? How do we actually get creative? And it's something that for people in rural regional areas, we're pretty used to that. It doesn't mean it's okay. It doesn't mean it's acceptable, but it's something that the complexity of this practice environment just adds to that, rather than actually kind of shifts it and means we can't, just means we have to get a little bit creative. In regards to telehealth, I think because of COVID in particular, there's obviously been a lot more attention to it. Telehealth can be great as a means of tech engagement, I guess, with young people, if that's actually where the young person's at in engaging. That's one of the important things that I think actually practitioners using and clinicians using telehealth have now found. Does it actually work for the young person? Is that their preferred kind of form of engagement? Does this actually work best for them? Is this the safest kind of best engagement opportunity we have? Sometimes we've done it out of practicality and need, and COVID's a clear example, and rural regional distance is the other. Other times, I think it's really important that you have to acknowledge there have to still be skilled clinicians on the end of that telehealth engagement. So there's no point actually just setting people up with a telehealth engagement if that relational engagement factor actually wasn't there in the first place, because how helpful and therapeutic is that for a young person? The other bit that I'd also say is an assumption about telehealth use. If you live in rural areas, you might not actually have, like I laughed earlier when you had your internet drop out a little bit, Carolyn, but that's a reality. You know, we actually have tech issues. We have systems network issues. So just because you're setting up the tech still doesn't mean that it's necessarily accessible. So again, just having that as that sense of reality, I think, is really important to ground us.
And I'd just probably add in there, as you are probably all familiar with a year or two down the track, that telehealth has some very specific issues around safety, that we cannot set up the same safety criteria that we would if we were in a closed room where we knew exactly where the doors were, we knew exactly who was listening inside and outside those doors. We know, or at least my experience at the Children's was that a lot of the what becomes some very violent interactions between parent and children have been over internet access and tech issues. We know that young people are more tech savvy than all of us. So we really need to have that caution, I suppose, in two senses. A, to find out if telehealth is working for the young people and for the family members. It can absolutely create more opportunities for access. It can absolutely mean that we can talk to mum while she's walking around the park with the dog, because that's the only time she's alone and feels safe. But it can also mean that we don't actually know who's listening, and we don't actually know what's safe. And if we can't guarantee that, then we're not guaranteeing a safe starting point for those conversations. So I just put that caution there, that it's both a potential and a potential risk. And that can only ever be deciphered by really engaging with the individual family and the members of that family you're working with. So I think it's really complex to do parent-child work together over a screen when you're far away. I think there are some good opportunities for independent access, particularly for some young people who are very resistant to turn up to a service. It's not their environment to sit on the other side of a desk, so a computer can be. But again, it's all the pros, all the cons. So whenever we talk about telehealth with families, we talk a lot about creating that safety, really intentionally asking those questions. As many of you will have become familiar with, sometimes you can set up a kind of code word that says situations change. You know, if I say blue tack, it means someone's come into the room. We change the subject. Those are really important considerations.
Yeah, thanks, Danny. That's, yeah, obviously a really important consideration. I think something which practitioners in all fields have had to come to grapple with, that idea of this is actually quite different from a traditional sort of setting where we're in a room and I can see what's going on for the person I'm working with. We might just round out this little panel discussion. Just, I guess, to put it to panelists, what would be your key takeaway, I guess, and what I'd really like to ask about is how we can continue this idea of collaborating between sectors so that we can, you know, I guess continue to work in the way that is going to best service the, you know, a young person and their family in that way that we talked about, you know, working holistically, working systemically. Yeah, like any key takeaways or recommendations or thought of the day?
Mine always is to continue to collaborate, continue to keep using information sharing, continue to look at best practice and speak to other sectors. I think we're not always gonna get it right. There might be communication breakdowns, but the more we can learn from each other and the work we're doing, we don't need to be experts in each other's sectors, but we're so lucky in Victoria to have this MARAM framework where we can start to work together effectively. And at the end of the day, we all have the same goal. And that is, when there's family violence present, adolescent violence in the home, we want to lower that risk. And we want to, you know, have these happy, healthy families. We want everyone in Victoria to feel safe and live free from violence. So keep being curious, keep asking questions, and just keep sharing and speaking to each other. That would be my takeaway.
I think mine would also be to have that position of curiosity, like I mentioned earlier, but also to have some professional humility. So I think I know how it feels as a practitioner to feel like you are sitting with all the risk and how stressful and how overwhelming that is, particularly if you then feel like there isn't actually this natural service sector that's going to just neatly kind of pick up and hold this family. In fact, you might be the one holding it, and the complexity of how that feels is really tough. But I invite practitioners and clinicians to keep on sitting with some professional humility about that. Most people in other service sectors are still wanting to support safety. They're wanting to support risk. They're wanting good outcomes for young people and families. And that is something that when you perhaps see a gap in a service system, it's easy to then lean into that frustration instead of kind of switching that energy to go, all right, what can we do about this? How do we, exactly as Annette is saying, how do we actually kind of come back to a collaborative space? How do we hold this together as service systems? Or if you feel like it's not meant to be held by a service system, how do you kind of name that? How do you actually invite some curiosity then for another service system and invite some accountability from them too? So I think that's the trickiness of the background work that we're doing when it comes to young people who are using violence in this way, because there isn't sort of this neat systemic response at the moment that meets everybody's needs. So I think we have to have all of those factors and some energy around that.
I'd probably just echo what's been said already. Obviously, you've heard my strong views around engaging the adolescent as a person first, so that's always my first takeaway. But equally so, I would just say that, you know, many systems, as Courtney has said, have got a role. Mental health can do a certain part of the work. Often that needs to be sequenced. So when a whole family is in trauma, it's actually limited what we can do. So think about the sequencing of where this family is turning up for you, but also think about in much the same way as with victim survivor adults with family violence, if we don't ask, they won't tell. The degree of shame for families, the degree of holding for parents who are fearful of their child, but of the system as well, find sensitive ways to have private conversations with, whether you're working with the parents or the children. Begin to be that curiosity again. Think about what you're really trying to say when you're asking, do you feel safe at home? And give space to listen to that response.
Excellent. Thank you so much. There's some really good key takeaways there, and I've really enjoyed, getting your insight and your perspectives from the roles that you hold, and looking at the ways in which, I guess there are those intersections between adolescent violence and mental health support. I think someone's written a question in there, and I know we are very short on time, but I thought it was a good one. It was actually, I think, primarily posed to Maddison, and I think Maddison just did answer briefly, but the question was, do you have any data on how many of the sample of young people had accessed any specialist domestic or family violence services? And I'm wondering to what extent mental health services have become the default service pathway for AVITH users and victim service providers. Maddie, did you want to talk briefly about that? Is Maddison still there? Yep.
I'm here, sorry. How did I answer that question? I forgot. No, we didn't in the sample that we had. We only had their mental health service contacts, unfortunately, with no additional information about whether they were accessing any particular services at the time of the index incident. But still, definitely something that needs to be investigated further. I think, there's a paper in there that I just referred to. It was actually done by looking at the amount of young people engaging with the Alfred Kims who were engaging in violence in the home. So I don't know if that might be of interest. They might provide those details around whether they were engaging with a special family violence service as well. I just can't remember off the top of my head.
Yeah, no, that's good to know. Was there any, Danny, you mentioned that might potentially be true for some cohorts of young people, but not necessarily all?
Yeah, look, I think my experience is that, and particularly thinking about Maddie's study, there will be a cohort of young people who come to police attention and then stream through the police and justice pathway. There will be another cohort of young people that get streamed through the emergency department and mental health service systems. So I don't think those two worlds often meet. So I do think, again, coming back to that what I was saying earlier about it depends how we're defining the behaviour and therefore what stream they go down. I really strongly believe that there's some very different presentations, so particularly for the slightly younger adolescents who might be presenting with a range of neurodiversities or other sort of developmental diagnoses being sought. They might not end up in police attention very often, but they will absolutely end up as high-end users of acute and ongoing health and mental health services. And I also think that I've lost my thoughts, so I'm not going to try and catch it.
That's okay, no problems at all. I am sort of conscious of time. We have a couple of other questions in the chat box there, but what I might do is if we wrap things up for now, I can possibly get our guest presenters to have a look at those questions, and we can maybe include a couple of dot point responses, which we can send out along with the link to this video for people who couldn't be with us today. So I'll just take a second now just to quickly thank again all of our guests and panelists, Maddison Riachi, who I kept referring to, Maddie, I hope that was okay, Danny Gold, Courtney Lecanto and Zanetta Hartley. Thank you so much for your time and your insights today. And I suppose I'll just do a plug really quickly for the webinar series. We try to hold these monthly, so we'll send out an invitation as soon as we can for the next event that we'll be hosting. And in the meantime, there's some contact details there if you'd like to get in touch with myself or Emma for any of the information that you're looking for, or resources that you think would be really useful for yourself or colleagues. Reminder that there'll be a really quick survey after you exit today, and that will also be a chance for you to just give us some quick feedback about what will be helpful for you, topics, modes of delivery. Is a webinar the best? Should we be doing information sheets? Let us know what you think. So thanks again, everyone, and we'll see you next time. Thanks.